Flat bones are thin, typically curved plates. They protect organs and provide areas for muscle attachment. Examples include the sternum and cranial vault. They feature a spongy layer between compact bone. Bone tissue is a structurally dynamic and metabolically active connective tissue. It adapts to systemic demands and localized mechanical strains.
Bone possesses a unique biphasic composition. Its inorganic phase is primarily calcium hydroxyapatite. These crystals provide high compressive strength. Bone and cartilage are fundamentally different. Their structures determine how they function. Bone is rigid and calcified for support. Cartilage is flexible for shock absorption. Let's compare cartilage and bone. Cartilage is avascular and highly hydrated. Bone is highly vascularized and mineralized. Only bone has direct cell communication.
Flat bones are organized like a sandwich. They have outer plates of dense, compact bone. Cortical osteons make up the hard exterior. In the cranium, this core is the diploe.
Flat bones have dense outer and inner layers called cortical tables. This compact bone is composed of cylinders called osteons. Concentric lamellae are rings of calcified matrix. Positioned at the core of each osteon, the central canal houses vessels and nerve fibers. Osteocytes extend processes. This facilitates nutrient delivery. Outer circumferential lamellae are beneath the periosteum. Inner layers line the internal marrow cavity. Concentric lamellae form the rings of active osteons. Interstitial lamellae are fragments between them. The interior of a flat bone is composed of spongy bone, called diploe. It is organized as a dynamic meshwork of trabeculae. This arrangement reduces bone mass while the periosteum covers the outer cortical surface. The outer layer is composed of dense connective tissue. The inner cambium layer houses osteoprogenitor cells. This lines the trabeculae of spongy bone. It consists of flattened bone lining cells. These can differentiate into active osteoblasts.
The periosteum anchors to bone via Sharpie's fibers. These collagen bundles unlock deep structural integration, transmit mechanical forces from muscles to bone. This process orchestrates vital bone remodeling.
Intramembranous ossification involves direct bone formation. Mesenchymal cells condense and differentiate. Osteoblasts secrete osteoid without a cartilage model. This forms our flat bones. Bone morphogenetic proteins stimulate mesenchymal cells. This expresses the master transcription factor RUNX2, committing them to the osteoblast lineage.
Osteoblasts form a primary ossification center. The matrix calcifies, trapping them in lacunae. Bony spicules form a TRA network. Parallel layers form enclosing the diploe.
Endochondral ossification forms the initial cartilage template. The master transcription factor SOX9 regulates this process. It drives the expression of collagen and aggrecan. Central chondrocytes undergo hypertrophy. They secrete type X collagen and alkaline phosphatase, which calcifies the matrix and induces apoptosis. Blood vessels then invade osteogenic cells. The cranial vault develops via intramembranous ossification. The diamond-shaped anterior fontanelle typically closes between 13 and 24 months. Posterior and lateral fontanelles close much earlier. Ribs develop from the sclerotome. Primary ossification begins at the costal angles. Sternal ends act as metaphyses. At puberty, secondary centers appear. They fuse by age 25. Sternal bars appear in the 5th week. They fuse and segment into 6 sternebrae. Ossification centers appear in a craniocaudal sequence. Fusion completes by age 25. The scapula develops through both intramembranous and endochondral ossification. Postnatally, remaining regions ossify 7 or more secondary centers. The primary ossification center for the scapular body and spine appears at the 8th week in utero. This center is typically present at birth.
Timelines of secondary ossification include scapular structure, 15 to 18 months postnatally, and complete fusion age, 15th year of life. The acromion process has 2 secondary centers. They appear at puberty, and complete fusion occurs between 20 and 22 years of life.
Let's review secondary ossification. The glenoid cavity has 2 centers. They appear between 10 and 11 years. Complete fusion occurs later, 16 and 25 years. Follow for more quick anatomy facts. Secondary ossification of the scapula occurs at the medial border and inferior angle. These 2 centers appear at puberty and complete fusion between ages 20 and 25. Flat bones form a protective dome. This dome consists of an outer table, middle diploe, and inner table. Sutures allow the skull to expand. They typically fuse by age 26. The pterion is the weakest part of the skull. The middle meningeal artery runs right beneath it. A fracture here can cause an epidural hematoma. The thoracic cage protects vital organs. Ribs articulate posteriorly with vertebrae, demonstrating the 2 synovial joints. This is rib articulation. True ribs connect directly to the sternum. False ribs connect indirectly. Floating ribs have no anterior attachment. Costal cartilages provide the elasticity for chest expansion. Males show a fork-shaped calcification pattern. Females display a central candlewick pattern. The first rib forms dense bony plates. During shoulder abduction-duction, two distinct movements occur. The scapula rotates 60 degrees. The scapula is a flat, triangular bone. It articulates with the clavicle and the humerus. Shoulder movement requires a coordinated rhythm. Motion is distributed in a 2-to-1 ratio. Shoulder elevation has two phases. First, the setting phase. The joints move in a consistent 2-to-1 ratio. This rotation prevents mechanical impingement. Abduction is driven by the supraspinatus and deltoid. The serratus anterior and trapezius rotate the scapula. The rotator cuff dynamically stabilizes the humeral head. This creates a perfect kinetic chain. Flat bones are central to adult hematopoiesis. Their spongy core is filled with highly cellular red bone marrow, produces regulatory cytokines. These control the commitment of hematopoietic stem cells. Within the osteoblastic niche, quiescent stem cells remain dormant. Driven by chemical signals, re-niche, they find signals to proliferate. Finally, they undergo transendothelial migration.
Located adjacent to the inner cortical bone surface, lined by endosteal osteoblasts. This niche maintains HSC quiescence through localized signaling molecules.
Within the bone marrow, stem cells seek the vascular niche. Erythroblasts become red blood cells. Megakaryocytes release platelets to regulate clotting. Myeloid and lymphoid lines complete maturation. During fetal development, hematop occurs in virtually all bones. Postnatally, red marrow converts to yellow. In adults, it is restricted to the axial skeleton. Under stress, yellow marrow can revert. Due to accessibility, flat bones are used for interventions. The needle enters the marrow, but must not cross this line. Here, the spongy marrow is safely aspirated. Perforation risks lacerating the ascending aorta. The adult sternal body has a thin cortical plate. Insert the needle obliquely at 30 to 40 degrees. Advance with a rotating boring marrow motion. Entry is marked by a decrease in resistance. Aspirate a small volume of fluid. The surgeon makes a vertical midline incision. The sternum is cut down the middle. Retractors are placed to expose the mediastinum. Dissecting fat reveals the left innominate vein. This is followed by the aortic arch and its major branches.
The sternum is closed using stainless steel wire sutures. Sternal complications occur in 0.5 to 5%. Dehiscence and non-union can result from coughing.
Flat bones have unique origins. Craniosynostosis is premature fusion. Mutations cause receptor activation. This triggers premature bone deposition. This alters skull growth. Premature suture fusion prevents the skull from expanding. The brain grows parallel to the closed suture, causing dysmorphism. Sagittal fusion leads to a long, narrow skull. In severe syndromic cases, such as Apert, Crouzon, or Pfeiffer syndromes, premature fusion of multiple sutures can restrict brain, increasing intracranial pressure and impairing cerebral blood flow and neurological development. Cleidocranial dysplasia is a rare genetic condition. Mutations in the RUNX2 gene impair osteoblast differentiation. This delays mineralization in both intramembranous and endochondral bone.
Calvarial dysmorphism features large, wide-open fontanelles, nasal bridge. Midface recessory Warmian bones are also common. These sutures may remain patent throughout life.
Sprengel's deformity. The scapula fails to descend. It remains elevated and dysplastic. An omovertebral bone may form. This restricts shoulder movement. Klippel-Feil syndrome is caused by mutations in the GDF6, GDF3, or MOX1 genital fusion of adjacent cervical vertebrae. Aproxef is characterized by a short neck. Pectus excavatum is a congenital chest wall deformity, characterized by an inward depression of the sternum, severely compressing the heart and restricting lungs. These are anomalies of the thoracic skeleton. They are caused by overgrowth of costal cartilages. Pectus carinatum is an outward protrusion. Patients may experience pain and distress.
With age, flat bones change. After menopause, l'estrogen reduces bone formation. The internal meshwork undergoes thinning and fragmentation. This increases the risk of wire pull-through.
Cranial flat bones form via intramembranous ossification. Pterian fractures can cause epidural hematomas. Craniotomy allows access to the brain. We assess fontanelle tension in infants. The sternum is a primary flat bone. Its vascular spongy layer is enclosed by a thin anterior table. Median sternotomy provides critical surgical access. Pathologies include pectus excavatum. Ribs are slender flat bones formed via They withstand torsional forces during respiration. Pathologies include fractures and cartilage calcification. Interventions range from X-rays to surgical resection. The scapula is a flat bone with mixed ossification. It anchors muscles and drives the scapulohumeral rhythm. Pathologies include winging and Sprengel's deformity. Surgery may require resecting omovertebral bones.
In conclusion, flat bones provide protection and offer broad surfaces for muscular attachment. From the cranium to the pelvis, they form the essential protective casing of the human body.